Hey everyone, welcome back to Urgent Care Stories. Today's episode is going to be about a lady that I saw a few months ago. This was a patient that you don't see there very often, but it is something that was really interesting to see in clinic because when it presents, you often hear some descriptors for the type of case that you're going to see when you're learning this stuff in school, and then to actually see it come through, it was exactly how you would expect it to come through in the clinic. So the story basically goes, this was a woman in her 40s or 50s, fairly healthy. I don't think she had any significant immunocompromisation, no diabetes, nothing crazy. She basically just came in. She was having a sore throat for about a week, but then in the last 24 hours, the throat pain has gotten significantly worse. So somebody that comes in like that, initially you're going to think, what is she at risk for? So strep, like we talked about with the Centaur criteria in the past, is not as common as you get over the age of 44. Still a possibility. Peritonsillar, retropharyngeal abscesses, those sorts of infectious causes. We could be thinking about flus, streps, influenzas, viral pharyngitis, stuff like that. Those are kind of the different thoughts that we have. So going through the history, she's been afebrile, really hurts to swallow. It just feels really, really painful in the back of her throat. When you have her come in and you start talking to her, her voice is very off. And pardon me for trying to do this, but it sounded like she had something really hot in her mouth. You might call that a hot potato voice. That's how it's described in medical literature. And that's exactly what this woman sounded like. It sounded like there was something really hot in the back of her throat, and that was how she was trying to talk around it. So obviously hearing her voice sound very different was the first clue that, hey, this is odd. Next thing I do is my physical exam. So I feel her lymph nodes. She's got significant, very large anterior cervical adenopathy, very tender to palpation on both sides. Next thing we do is look in her throat. So I have her open her mouth, and her soft palate and her uvula is significantly depressed and shifted forward. And right then and there, we can make our diagnosis. This is a retropharyngeal abscess. Retropharyngeal abscess is basically a pus pocket or an abscess that takes up space behind the pharynx. So what it does is it shifts your soft palate, shifts your soft tissue of the neck forward, and it changes the way your voice sounds as you talk, as it changes the space that it occupies. This is something that there's a couple of different ways you treat these. The first line, it all depends on what their airway looks like. So if the patient is having trouble swallowing or trouble breathing, those are indications that they usually need to have an incision and drainage, or basically a needle that goes in and drains it under ultrasound. That is something that an ENT specialist or someone in the ER would perform under direct imaging. It's not something that I would recommend performing in an urgent care setting. In this case, looking at her, we say, hey, she's able to talk, she's able to breathe, she's not short of breath, she still has a clear airway, but it is significantly swollen, and she's still able to swallow foods. I do a soft tissue neck, so it's a lateral x-ray of the neck, and sometimes you can see some fullness or some shifting of the airway forward. In this patient, I didn't see that. The airway was still clear and still in line the way we would expect it to be. So what do we do? Well, this is one of those situations where you would totally be appropriate to send this person to the ER. To me, I said, look, these are our options. We can send you to the ER. They may perform an incision and drainage or a needle aspiration of the area, drain the fluid out of there, and put you on antibiotics to treat this. The other option is we can try to treat you as an outpatient and have a very close time frame. So if you notice in the next 24 hours, symptoms are worsening, you're having trouble breathing, you're having trouble swallowing, or the pain is getting significantly worse, those are all reasons we want you to go to the emergency department. I give the patient the options. I say, look, the worst case scenario is this thing blocks your airway and you can't breathe. And I explained all the kind of risks and benefits and all the different stuff. And she made an informed decision, and she decided, you know what, I'd like to try to treat this as an outpatient. So what did I do? Well, I gave her 125 milligrams of Solu-Medrol, and I gave her 1 gram of ceftriaxone intramuscular. Ceftriaxone is a third generation cephalosporin. It's a broad spectrum antibiotic. And then the Solumedrol is a fast-acting steroid. The goal of the steroid is to reduce the size and the edema in the area to help with the swelling of the airway. And then the antibiotic is to fix the infection. The good news is a lot of these retropharyngeal abscesses, you don't have to cover against MRSA, so you typically are able to do some different types of medications. Third-gen cephalosporins are appropriate, different types of broad-spectrum amoxicillin-based drugs like Augmentin, doxycycline, those are appropriate choices. In this patient, I ended up choosing clindamycin. I put her on 300 milligrams 4 times a day, and then I put her on a Medrol dose pack, which is a steroid taper over 5 days. I said, I want to see you back tomorrow unless you've gone to the ER. So we give her all the meds, we send in the instructions, we send in the medications to the pharmacy. The next day she comes back in for a recheck. It was the most significant 24-hour change I've ever seen in a patient. She came in the first day sounding crazy, hot potato voice, really, really odd voice. When she came back in the next day, the swelling had significantly reduced. Her voice was almost completely normal. Her pain was almost completely gone. It was a pretty significant improvement in 24 hours. So it tells us that, hey, we did the right thing. We saved this person a trip to the emergency department. She was able to get the care that she needed. But this was an interesting case in the sense that you hear that term hot potato voice when you learn about this in the textbook. I always thought, well, that's a weird thing to hear, or I wonder what that sounds like. And I'm not kidding. The minute she came in and I heard her say the first few words, I was like, that sounds like you have a hot potato in your throat. That's exactly what it sounds like. So sometimes things you learn in the medical literature is exactly how it presents. Sometimes appendicitis will come in exactly how you would expect it to. Sometimes acute cholecystitis will come in exactly how you expect it to. So it's good to know those classic presentations, and this was one of those instances, guys. She did great. She had no issues, didn't need to have it drained. Antibiotics and everything treated this perfectly for her, so she had a great outcome. And it was just a really interesting case to see, and something kind of out of the norm for your regular sore throat complaint. So always make sure when people come in with a sore throat, I've had students in the past who don't really look very closely, or they have the patient open the mouth, but their tongue is blocking the whole view, and they say, oh, everything looks fine. Well, don't say it looks fine unless you can actually see it, because the only way I would have seen what this lady's throat looked like is if I did the proper examination. So always make sure that you're doing a thorough enough evaluation and a physical exam to find the findings that you need to have. Hope you guys enjoyed this video. I want to say thank you to everyone for reaching 100 subscribers. We're at like 110 subscribers now, so super grateful for all you guys for sharing this video and for subscribing and sharing my content. I'm really grateful for all of you, and I hope that you're all benefiting and learning something from this stuff. I will catch you guys in the next episode. We'll see you next time.